So come on up, let's do this. And round of applause.
So this is not fake news. And what it is, I know we're in Orange County, but the IBD has grown and now has for many, many years had the most abstracts from basic science through clinical. And it becomes more and more tough because the field itself is so grown and exploded that we have to deal with so many different things. So Jenny and Nimisha have organized things enormously well to talk about some very practical new data that's out there for your handling patients. And my talk this afternoon, is the kind of talks I give, is giving you where we are, if you will, and how we're trying to organize this in the very near future, not far future. So you guys, it's all yours.
Thank you very much. Okay, so what we've decided to do for the next session here is, hold on for 1 second. Why is that not working? So we decided to cover several topics that we felt that were most important and highlighted at DDW. So as you can see, there are quite a few topics that we're going to be covering today. Right now we're going to discuss safety, dysplasia surveillance, pregnancy, therapeutic drug monitoring, comparative effectiveness. We'll touch on some clinical trials. We'll touch upon some alternative therapies, discuss some biosimilars and some personalized medicines. So we'll start with safety with Nimisha.
So we're going to start with a case. We thought to put a case before each of these subject matters to make it more clinically relevant. So you have a 55-year-old woman who's on monotherapy infliximab for small bowel Crohn's disease for 5 years. She's currently in clinical and endoscopic remission. She's planning to undergo hip replacement. So what do you recommend to do with the infliximab to the orthopedic surgeon? Do you hold the dose? Do you have surgery at the trough dose? Do you give it 2 weeks later? Do you do no change? And then the other question the patient's likely going to ask you is, what's my risk of infection? Because that's our biggest concern as healthcare providers. So there are a couple abstracts relating to surgery in IBD patients. So one specific abstract was outcomes after joint replacement surgery in patients with IBD. This is based on a retrospective database, an insurance database claim. And what it was is they looked at patients from 2006 to 2014. They matched one case to 10 controls, and they were doing frequency matching. And the primary outcome was serious infections within the first 90 days after surgery. And they were looking at joint infections, surgical site infections, pneumonia, sepsis, and C. difficile. And I only put what was positive because there was very large tables. So what they did find is patients who had IBD did have a higher rate of having serious infections of pneumonia and C. difficile. The joint infection rate was exactly the same, so there was no increase. They did note that the 90-day readmission rate was higher in IBD patients compared to the controlled patients. So in conclusion from this study, what they did note is patients with IBD did have a higher rate of serious infections following just joint replacement surgery. However, upon a sub-analysis, what they did note was patients who had well-controlled disease for at least 6 months prior to surgery did not have this risk. The infection rates were higher in IBD patients, specifically for pneumonia and C. difficile. IBD patients did not have any more joint complications or issues related to their joint surgery compared to controls. They also noted patients who were on opioids, especially IBD patients, had higher rates of infections, and the 90-day admission rates were higher in the IBD patient population. There was also another study presented at DDW that was looking at the anti-TNF use in patients who were undergoing joint replacement surgery. And in this abstract, they did note that there was no significant increased rates of infections on patients who are also on anti-TNFs. Another study looking at the surgical literature is the use of vedolizumab and postoperative complications. And so this was looking at postoperative complications in non-intestinal surgery. This is at 2 centers. One was a Canadian center and the other was Mayo Clinic. And they did a retrospective chart review, and they were looking at 36 patients who underwent 34 different types of procedures. And what they did find is that vedolizumab patients with vedolizumab treatment on board undergoing non-intestinal surgical procedures had no overall increased risk of postoperative infections. It was as equal as to the control patients. They had the same number of rates of surgical site infections, reoperations, and readmissions. So this goes further to this gut specificity of vedolizumab. So that may be something that we may need to consider in certain types of patient populations. And the final one that I'm presenting on the safety in surgical site is the risk of postoperative surgical site infections after vedolizumab versus anti-TNF therapy, a propensity match cohort. This comes out of the Stanford group, and they did they used a research database. They looked at claims data. Their primary outcome was really looking at postoperative occurrence of surgical site infections within 30 days in IBD patients who are on vedolizumab or compared to anti-TNF therapy. They did propensity matching, and they did the matching based on age, gender, the type of IBD, their medication use, including steroids, immunomodulators, opioids, and they also looked at their malnutrition levels. What this table 1 is showing, they are identifying the patients both in the anti-TNF and vedolizumab group, and what they noted was the p-values, as you can see, are not significant in any of the things that they matched or saw. So what they did say, or their conclusion was that perioperative risk exposure to vedolizumab is not associated with any higher risk of developing surgical site infections after IBD-related abdominal surgery compared to anti-TNF use as well. The one thing that was very interesting is, though, in a multivariate analysis, was that malnutrition was the only risk factor in developing surgical site infections. So I think as we go forward in treating our patients who have IBD, who are undergoing surgery on biologics, I think we really need to think about their nutritional status as well as their steroid use.
Okay, so we're going to move on to dysplasia surveillance. So this is a question that comes up a lot with our patients that are in endoscopic and histologic remission. So Mr. T is a 60-year-old male, and he comes to your office to discuss his frequency of colonoscopies. Frankly, he says he's tired of it. He says he's had ulcerative pancreatitis for 25 years, and has had colonoscopy every 1 to 2 years for the last 17 years. And he feels fortunate that he hasn't had any dysplasia yet, but his last colonoscopies have been so normal, and he just doesn't know, does he still need to be doing this? So what do you say to him? So you can say, yes, you still need your colonoscopies every 1 to 2 years. B, you can say you have a colonoscopy in 5 years now. C, you can say, oh, no, you don't need any colonoscopies anymore, you're done. D, you can have a colonoscopy in 3 years. So the reason why I bring this up is because this is a very busy slide intentionally. Our recommendations are quite confusing. So if you look at the European guidelines for low-risk for populations with for endoscopic screening, they say that basically you can actually stretch out this surveillance to every 5 years. And this is based on various definitions of what's considered to be low risk. And then if you look at the American guidelines, this is a little bit different. So they say for AGA, every 1 to 2 years, after 2 negative exams, hey, you can do 1 to 3 years. And then for ASGE, they say you can lengthen beyond 1 to 3 years if you've had endoscopic and histologically normal studies on 2 or more exams. So this can be very confusing, and so this multinational 15-year cohort study really tried to address this question. So the study aims were to assess whether 2 consecutive negative surveillance colonoscopies can reliably predict a low risk of advanced colorectal neoplasia during follow-up. So the question here is low risk really low risk? So here there was 3 cohorts involved. So it was Mount Sinai Hospital, 7 centers in the Netherlands, and in Canada, University of Manitoba. They excluded patients with Crohn's disease without colonic involvement, ulcerative colitis with localized proctitis, or a prior history of advanced colorectal neoplasia, or advanced colorectal neoplasia at the time of the first recorded colonoscopy. And they included patients that were enrolled in a colorectal cancer screening surveillance program. They had about 2,191 patients involved, and these patients had at least 2 surveillance colonoscopies with pathology, followed by at least 1 other mode of pathological assessment on follow-up. And on definition, they said a negative colonoscopy was someone that had no dysplasia, no endoscopic disease activity, no stricture, or no post-inflammatory polyps. A positive colonoscopy had at least one of the above. In this analysis, all high-risk patients were removed from the primary analysis, and the outcomes were to look at incidence rate of advanced colorectal neoplasia following consecutive negative surveillance colonoscopies in a low-risk group. They did look at the high-risk group later on as well, and what you can see here is the total follow-up time after that first colonoscopy is roughly 6 years. And after the 2 colonoscopies, the follow-up time is roughly 3 to 5 years. And here, if you've had 2 negative colonoscopies, that risk of advanced colorectal neoplasia was 0%, which is really good news. If you've had negative and then followed by a positive colonoscopy, that went up to 1.1%. And if you had a positive colonoscopy followed by a negative, that went to 1.8%, and 2 positives went to 3%. So here you can see in this Kaplan-Meier curve, the green being 2 negatives and the positive being the dotted line. If you've had no cases, there were no cases of advanced colorectal neoplasia developed if you've had 2 negative colonoscopies. Now, they did look at the high-risk patient population as well, and they found that if you do have, that risk is still low of developing advanced colorectal neoplasia, but it's not negative. So that's there. So the conclusions and why this is important is that the patients that have 2 negative colonoscopies are considered really a low-risk group. So 30% with low-risk features had 2 negative colonoscopies in this study period, and having 2 negative colonoscopies predicted a low, potentially negligible risk of having any advanced neoplasia on follow-up up to 3 to 5 years. So the issue here is that the follow-up time for the study was a median of 4 years. So we don't really know what happens beyond 4 to 6 years in the patients that have had 2 colonoscopies. And unfortunately, we can't really say no colonoscopies because 10.3% of the patients still developed low-grade dysplasia upon follow-up. So I thought this is a very important study. It's actually been published in Gut 2018. Okay, so going on now, so this is our same patient, Mr. T. He's had now, you scoped him and he actually has low-grade dysplasia now. He's been, obviously, we've talked about before, in remission on mesalamine of 2.4 grams a day, and he has a flat visible discrete lesion noted on chromoendoscopy that you removed. So how do you counsel him now on the risk of progression from low-grade dysplasia to advanced lesion? So we know now with the scenic guidelines that basically if we see the lesion with chromoendoscopy, if it's discrete and if it's resectable, we try to remove it, and we try to avoid the colectomy in these patients. But our studies are variable. So the studies for so far to see the rates from progression of low-grade to high-grade, we've seen percentages of anywhere from 10 to 50%, with follow-ups anywhere from 32 months to 10 years, with studies that have been with only 29, 18, 46 patients. So these studies have been very small. So I thought this study was actually very nice. It was from a Dutch group that looked to determine long-term cumulative advanced neoplasia risk incidence and to identify risk factors for advanced neoplasia development in a nationwide cohort of IBD patients that have low-grade dysplasia. So I thought what was so strong about this study, they had 2,738 patients with colonic low-grade dysplasia, and the median follow-up time was 9.5 years after that initial diagnosis of low-grade dysplasia. 15% of these patients underwent subtotal colectomy, and the median time to development of that advanced neoplasia was roughly 4 years. And what you can see on the curve on the right is that they give basic estimates that you can actually say to your patients now. So after 1 year, that risk is roughly 3.5%. After 5, it goes up to 9.1%, and 10 years, 14%. By 15 years, that risk goes up to 22%, and then 20 years, it goes to roughly 30%. So I think these are really important numbers that you can actually tell your patients to help counsel them about the risk benefits of further surveillance versus proctocolectomy. All right, so we're going to move on to pregnancy.
So I know that a lot of people fear pregnancy. So in this day and age of biologics, we have a lot of information from various groups in Europe, as well as from Dr. Davin's group from the Piano Registry about the use of anti-TNF agents and immunomodulators during pregnancy. But now with the newer biologics of vedolizumab and ustekinumab, we don't have as much data. And more of our patients are going on these drugs, and we need to know how to counsel them. So we have a 33-year-old female with small bowel Crohn's disease for 10 years who's currently on ustekinumab in clinical and endoscopic remission. She's now asking about getting pregnant. In addition to recommending a consult with a maternal fetal medicine specialist, what do you recommend? Do you have her stop the drug? B, change over to certolizumab because of the FDA indication and label? continue her drug of ustekinumab, stop all her medications, or do you have her change over to vedolizumab? So the first study I'm presenting is pregnancy outcomes in women exposed to ustekinumab. This comes from Dr. Ma David and the Janssen group. And basically what they looked at is they were looking at the company database, safety database, all the way through June of 2017, and they looked at maternal use of ustekinumab in patients who had this drug for psoriasis, psoriatic arthritis, and Crohn's disease during pregnancy or within 2 months prior to conception. They noted there were 206 reports, 164 patients who had psoriasis, and 36 patients who had Crohn's disease. The average maternal age in this group was 30 years. The reported cases are from various sources of clinical trials, solicited sources, spontaneous reports, and literature sources as well. And what they found is that the rate of spontaneous abortions was comparable to the rate of that in the general population, so no increased risk there. The percentage of congenital anomalies was similar to the overall incidence in the general population. However, this is very limited availability of their data, but they said as of right now, there's no specific risk that they counsel their patients on. As for the timing of when do you stop the biologic ustekinumab you're giving every 8 weeks, you're going to try to time it probably as we do with the anti-TNFs in giving it the last dose early on in the 3rd trimester. There's also an abstract about vedolizumab treated female IBD patients. We do know an interesting thing about vedolizumab is that there are human studies that do show the expression of MADCAM1 in the placenta during the 1st trimester, but not in the mature placenta. So the aim of this study from this group was to evaluate pregnancy outcomes in vedolizumab-treated female IBD patients. It's once again a retrospective national observational study from Europe looking at these outcomes. And what they did find, they identified 23 pregnancies, 18 were in remission, and 5 were flaring at the time of conception. And what they did see were certain maternal complications. 1 patient had eclampsia, 2 had premature rupture of membranes, 1 lost the fetus due to chorioamnionitis at week 22, 1 had active termination, so chose to terminate the pregnancy, 1 had a miscarriage, and then 5 underwent C-sections for Crohn's disease. Of the infant complications in this group, 1 had IUGR, 2 had congenital anomalies, 1 was small for gestational age, and 4 were preterm births. So this is, though it is a very small number, what we do notice that you can't make any clear conclusions. However, it does seem there were a little bit higher rates of prenatal and some congenital abnormalities noted. And so there was another study from an Israeli group, which I just posted here for your reference. They actually found some similar data as well. So we're going to switch to therapeutic drug monitoring.
Okay, so this landscape is a little more confusing. So why are we doing therapeutic drug monitoring? So we know that there is intra-individual variability in drug pharmacokinetics, and that this depends on personal factors such as gender, BMI, disease factors such as disease severity, location of the disease, and drug factors such as dosing, immunogenicity. But we currently are doing this to help us understand better why people are losing response, and the question, and that's more thought to be reactive TDM. So these are patients that have quiet disease to evaluate reasons for loss of response, or proactive TDM. That's the other group where we can be doing TDM, and this is where patients are have quiescent disease, and we're trying to optimize their therapy. So when we think about reactive therapeutic drug monitoring, overall, with all the different guidelines and consensus statements, there is pretty much a consensus here that reactive therapeutic drug monitoring is helpful. If you're losing response and you want to evaluate the cause of that, it can help you determine what the cause is of loss of response. And here, as an example, so we look at whether patients have subtherapeutic drug concentrations, and whether or not they have the presence or absence of antibodies. So if they have subtherapeutic drug concentrations with undetectable antibodies, the thought is that they have a non-immune-mediated drug failure. For this, you can potentially increase the dose of the drug or decrease the intervals between dosing to try to capture response. If you have subtherapeutic drug concentration with detectable antibodies, you have an immune-mediated pharmacokinetic failure here. And changing to a second agent along with an immunomodulator currently is a recommendation. Now, if you have therapeutic drug concentrations with undetectable antibodies or with detectable antibodies, the thought is that there possibly is a mechanistic or pharmacodynamic failure here, and potentially changing to a new class of medications is the recommendation. So here with immune-mediated pharmacokinetic failure, I wanted to alert a nice abstract that came out that really supports our evidence to switch to another drug in class and consider adding an immunomodulator. So this French study, the study aim was to compare two therapeutic strategies to the loss of response to the first anti-TNF optimized after having unfavorable pharmacokinetics with the first agent. So they were randomized to monotherapy, switching to a second anti-TNF therapy, or combination therapy, which is switching to a second anti-TNF therapy with azathioprine. So patients that had failed optimized anti-TNF with undetectable anti-TNF levels with high antibodies. So these patients had either infliximab at 10 mg per kg every 8 weeks or adalimumab at 40 milligrams every 7 days. So they had that for at least 4 months and demonstrated failure, immune-mediated failure. They were randomized to one of 4 groups. So they could, if they were on the infliximab group, they were randomized to adalimumab with azathioprine or adalimumab monotherapy. If they were already on adalimumab, they were randomized to infliximab with azathioprine or infliximab monotherapy. So patients so there were 45 patients in combination therapy and 45 in monotherapy. Clinical failure, I have the definition there for you to see. And they also measured unfavorable pharmacokinetics as well, and they followed the patients out for 24 months. And really the upshot of this is, so in these Kaplan-Meier curves, the top are the red and the blue are patients on combination therapy. The black and the green, those are in patients on monotherapy. So patients that were on adalimumab azathioprine or infliximab azathioprine, they had fewer rates of clinical failure, and they had fewer immune-mediated pharmacokinetic failure. So really, the conclusion of these studies suggests that it is significantly better, if you're going to be switching to another agent in class, to switch to a second anti-TNF with azathioprine than just to another anti-TNF therapy alone without the azathioprine. Okay, so I figured we should talk a little bit about proactive therapeutic drug monitoring. At this time, the AGA says that in patients with quiescent IBD treated with anti-TNF agents, the benefit of routine proactive therapeutic drug monitoring over no therapeutic monitoring is uncertain. And this really comes from 2 randomized controlled trials that have been recently published. So one is the TAXIT trial, which I'll talk to you briefly about, and I'll talk about the TAILORx trial in a little bit. So the TAXIT trial took 263 patients, and these were patients that were stable responders on maintenance infliximab. And what they did was they found the patients that had undetectable or low levels of low trough concentrations. They optimized all patients at the very beginning. So there was an optimization phase first. And then after the optimization phase, what they did was they then randomized patients to concentration-based dosing for a target of 3 to 7, or they were randomized to a clinically based dosing. So I think the important part of this trial is that all patients were optimized. So if you can see on this chart that I'm showing you, the patients that had dose escalation in Crohn's disease, they had more patients in clinical remission and lower mean CRP levels when they were optimized. In ulcerative colitis, most of these patients were already in clinical remission with low CRP levels, so we don't really see those differences. So we do see that increasing the trough concentrations makes a difference in their outcomes. However, when you look at long-term, when the patients were actually randomized, over the long term, the remission rates in the 2 groups were similar. So the primary endpoint was remission after 1 year, and they were really the same. But you do see trends towards more rescue therapy in the group randomized to clinical therapy, and then more patients that stayed in the infliximab target range if they were randomized to proactive therapeutic drug monitoring. So here, the upshot of the study was that this did not support proactive therapeutic drug monitoring. And in the second study, what they did was they basically also took patients. This was a proof of concept trial that was not actually powered to detect a superiority of proactive therapeutic drug monitoring, but they took patients that were in maintenance, so they were already past the induction, and they randomized them to 3 different groups. So one group was a group where they had dose adaptation based on symptoms alone. The second group had dose adaptations based on symptoms, biomarkers, as well as their infliximab drug concentrations. In the third group, it was the same, and in those 2 latter groups, they increased the infliximab by either 2.5 or 5 mg per kg. And their outcomes were, the strongest part of the study was that they had very strong endpoint, which is sustained clinical remission at week 20 and week 54, and no ulcerations on endoscopy by central reading at week 54. And what's kind of puzzling and interesting about this study is those that were randomized to the symptom-driven dose adaptation did much better than those that had dose changes by infliximab levels biomarkers. And so it's a little bit of an interesting message, but it did not support proactive therapeutic drug monitoring. There are some criticisms in this study in that 60% of patients that had dose escalation had normal CRP and fecal calprotectin to begin with. So they were probably not really that active. And in the dose escalation groups, there were 53% of patients that had possible dose escalation based on symptoms that were avoided as the biomarkers were not elevated. So the symptoms, clinical symptoms may have diluted the effect of therapeutic drug monitoring. And when you look at the 3 different groups here, you see also that their infliximab concentrations are really similar all the way through. So it's even unclear whether or not they were really dose optimized. So because of these 2 studies, the current recommendation is that we can't really confirm the superiority of proactive therapeutic drug monitoring. However, there's certainly some hints that it is helpful. We do need future studies to really clarify the right time points for proactive monitoring. Is it during induction or in maintenance? And what is the optimal trough concentrations? I get a lot of questions. So where should I really be targeting my trough concentration? The question is, as a society, we don't really know yet. We can't give that target, and I think it depends on a lot of different factors and desired outcomes. And then the third question is, how often should we be checking proactive TDM for optimal outcomes? So I think there's going to be a lot of studies coming out in the future to really guide our therapy here. Okay, we're going to move on to comparative effectiveness.
Okay. So by this topic, we are talking about, now that we have different mechanisms of actions for our biologic therapies, how do we know which one is better, right? There's not been a head-to-head trial looking at that yet. So we'll start it out with a case, a 25-year-old male who is moderately active pan-ulcerative colitis for 1 year, who is currently steroid dependent and unable to come off prednisone. The patient has a lot of questions about safeties with biologics. And at this point, what do you recommend to do? Do you start an anti-TNF? Do you start vedolizumab? Do you start 6-MP? Or do you start Tofacitinib? This is our landscape. We have a lot of confusion. And so the patient's main issue was, what about safety? And what's safer and what's better? So what has happened recently is there is a consortium called the VICTORY Consortium, and what they are doing is to compare the effectiveness of vedolizumab to anti-TNF agents for both UC and Crohn's disease. It's a multi-center US-based consortium, and they include patients who have completed either induction with vedolizumab or anti-TNF between 2014 to 2017. So if you remember when anti-TNFs came out, and if you remember the TREAT registry, this is something similar to that, but with slightly different aims. It's a retrospective cohort. They do propensity matching, and I'm going to explain what that means in a second. They did look at patient characteristics, disease characteristics, and treatment history. And what propensity matching is, it's a statistical method which attempts to reduce bias by statistically matching certain covariates at baseline, which may predispose patients to respond better to one biologic to another. So another way of putting it is you're comparing apples to apples statistically. So the outcomes they're looking at were clinical remission, steroid-free remission, and endoscopic healing. And at DDW, they had multiple different abstracts and oral presentations from the VICTORY Consortium. I'm going to present one of them today, and I put a list also of the other trials that were presented. So the one that I'm going to present is the one where they looked at vedolizumab compared to anti-TNF agents for ulcerative colitis. And what they did in this study was they did a propensity matching, as I described, and they're matching them based on all these factors of age, gender, previous hospitalization, steroid use, extent of disease, and prior anti-TNF failure. When they looked at the different anti-TNF agents and concomitant steroids and immunomodulators, they did actually have to do some further statistical matching, and so that's why when they look at the large groups, the groups did have to go down in size for propensity matching. So visually what that looks like is when you are just choosing the patients who had vedolizumab and anti-TNF agents, they're assigned a score, and this is what their scores look like. But once you match them, you can see that their scores look more identical, but the cohorts went down from that. And what they did find in this particular cohort with the UC patients was that they looked at outcomes at 12 months, and they looked at the vedolizumab group and the anti-TNF group, and they saw that Clinical remission was higher in the vedolizumab group, steroid-free remission was a little bit higher in the vedolizumab group, and endoscopic healing was higher. And this was all adjusted for number of prior anti-TNF agents, concomitant steroids, and immunomodulator use. So I think what we're seeing from this, or the conclusion you can take home from this one abstract, is observational data of vedolizumab-treated UC patients had significantly higher 12-month cumulative rates of clinical remission and endoscopic healing, as well as steroid-free remission when compared to anti-TNF treated patients. Now, there were several other abstracts and presentations from the VICTORY Consortium group. These are a list of a few of them. They did one for Crohn's disease. They looked at the safety profile. They looked more also at concomitant immunomodulator use in the vedolizumab group. I will have to caveat and say that the VICTORY Consortium is funded by Takeda, so you can interpret that as you take that. Okay. So now we're going to switch gears and talk a little bit more about clinical trials and novel therapeutics.
Okay, so there is a flurry of activity here, and I'm only going to be able to scratch the surface of all the different therapeutics that are out there now. So I think that Tofacitinib actually deserves mention because it was our most recently approved, FDA approved on May 31st. So it is a novel small molecule oral JAK inhibitor. So these JAK inhibitors, these are small molecules that lie in the cytoplasmic tail of a cytokine receptor, and they directly or indirectly modulate signaling for pro-inflammatory cytokines, so IL-2, 4, 7, 9, 15, and 21. And, excuse me. And we already know from the OCTAVE 1 and 2 trials that Tofacitinib has been demonstrated to be effective as an induction and maintenance therapy for moderate to severe ulcerative colitis. So it met primary endpoint of clinical remission at week 8 and the key secondary endpoint of mucosal healing at week 8. And when you see the numbers, you see they seem to be kind of small, right? 18% remission, 16% in OCTAVE 2. But really, I think these numbers are kind of driven down by the fact that the central reading was also done in this particular study, which hasn't always been the case for prior clinical trials in UC. So when you look at Tofacitinib and how quickly it works, you can see that with the partial Mayo score, there's a clinically significant decrease in that partial Mayo score even by week 2. So it's thought to work fairly quickly, and we know that those patients that actually have remission at week 8, they go on and they have a pretty high maintenance of remission rate at week 52. So there have been several safety signals that were considered in the OCTAVE 1 and 2 trial, and that was infections with herpes zoster, some non-melanoma skin cancer, LDL and HDL cholesterol increases, gastrointestinal perforation, lymphopenia. So in this trial that was done as a safety follow-up to that OCTAVE trial, this had up to 4.4 years of safety data follow-up to look into these safety signals. And so what they did was they looked at incidence ratios of adverse events of significant interest. So they looked at death, serious infection, herpes zoster, non-herpes zoster opportunistic infections, malignancy, then this is excluding non-melanoma skin cancer, and then they also looked at non-melanoma skin cancer as well as major adverse cardiovascular events and gastrointestinal perforations. And as you look at this whole group, you really see that the signal that seems to linger is this signal for herpes zoster. You don't really see a strong signal for all the other adverse events. So as a safety consideration, I think that the herpes zoster risk is a real one, and there is a dose-dependent increase in that risk as you increase the medication dose. So now we do have the Shingrix vaccine. It's an inactivated recombinant herpes zoster vaccine. It's approved currently for immunocompetent adults greater than or equal to 50, and it had a 97% efficacy rate in persons greater than or equal to 50. Now in the immunocompromised groups, our ID colleagues say, we can certainly use it, but I haven't seen much data in IBD patients or in the immunocompromised group, and I think it'll be interesting to see. I'm sure there'll be some studies coming out in the future to see about efficacy and safety. In these patients, we should check LDL and HDL before and 4 to 8 weeks after starting Tofacitinib. And what's interesting is that ratio of the increase doesn't change. So the significance of this increase is still unclear, and there weren't any increases in cardiovascular events. Nevertheless, we should be checking for this. And there has been some reports of lymphopenia, and so I do still check CBC, CMP in these patients like I would with any other immunomodulator at 1 month, and then every 3 to 4 months thereafter. So then there was another nice trial that looked at, with our concerns with anti-TNFs about stopping therapy and restarting and whether it's going to be just as effective. This was a nice trial that looked to see what the retreatment effect was in these patients that had stopped Tofacitinib and then were restarted. So these patients were enrolled in the OCTAVE induction study and were responders. Then they were randomized to the placebo group in the maintenance study. And then they exhibited treatment failure between week 8 and 52, and then were enrolled in the open label trial where they received Tofacitinib at 10 milligrams of BID. And they evaluated clinical response, mucosal healing, and remission at month 2 and month 12. And really the upshot here is that you do capture quite a lot of response once you retreat. So roughly 75% of patients by month 2 had adequate clinical response that was recaptured and generally sustained and was well tolerated. Okay, so shifting gears, we're going to IL-12 and IL-23 inhibitors. So we all know about ustekinumab. So ustekinumab was our most recently approved drug for Crohn's disease. It's an inhibitor of the P40 subunit of the IL-12 and IL-23 cytokines. So then brazikumab and risankizumab are currently under development for Crohn's disease, and they're P19 inhibitors, so these are selective IL-23 inhibitors. So the question is whether or not selective IL-23 is actually potentially more effective and safe for patients with IBD. So more recently, there was a late-breaking abstract that was looking at mirikizumab, which is also another P19 inhibitor for ulcerative colitis. So in this particular study, it was a phase 2. They had 249 patients who had moderate to severe Crohn's disease. 63% of these patients were on previous biologic medications, and they looked at clinical remission at week 12. And you can see here that clinical remission rates were clinically significant in patients that were on 260 milligrams of every 4 weeks of the mirikizumab, and they also met the primary endpoint of endoscopic healing in these groups. So why is this important? This is the first data to really look at a selective IL-23 inhibition in patients with ulcerative colitis, and it's shown to be efficacious in the induction therapy for patients with moderate to severe ulcerative colitis, and that there's a trend towards efficacy in both biologic naive as well as biologic experienced patients, and that the adverse effects were actually pretty minimal and similar to patients that were placebo in the placebo group as well. Lastly, I'm going to talk briefly about apremilast for active ulcerative colitis. So this is a PDE inhibitor, so phosphodiesterase 4 inhibitor. And so what this does, it increases intracellular cyclic AMP, which is supposed to decrease our inflammatory cytokine production. So this is currently approved in psoriasis, and some reported side effects for the psoriatic population was depression, weight loss, drug interactions, and headache. And what they did here in this study was look at the ulcerative colitis population that were naive to biologics, and they randomized patients to 30 BID, 40 BID, or placebo. And really, you're seeing signals here for clinical remission and response, as well as mucosal healing in the 30 milligram BID group. So I think this potentially could be a promising therapy for maybe our naive to biologic group. So here, even the biomarkers were also supporting response. Some side effects that will need to be clarified and looked at will be headache, URI. There was kind of higher headache rates in these patients. Okay, so we're going to move on to alternative therapies.
So this is a big category, a very fun area for our patients, probably less so fun for us because we don't know what to always recommend, but I chose one abstract to present today. So you have a 35-year-old female who's newly diagnosed with ulcerative colitis, and she's asking about dietary recommendations and complementary alternative therapies as part of her management strategy. So what do you recommend? A, refer her to the internet or Dr. Google. B, send her to a dietitian. Or C, have her buy cannabis, because it's legal now in California. This is a big deal, so I figured this was more real life. So there was a study that was done looking at cannabis induces clinical and endoscopic improvement in moderately active UC. This is from an Israeli group, so you can take that from how we can compare it to our patient population here in Southern California. So what they did is they were looking to assess the effects of cannabis use in moderately active UC. So they randomized a total of 14 patients to each group. One was a group that took standard therapy plus cannabis, and then one group that just took their standard therapy, but they had a placebo cigarette. And what was in the cannabis cigarettes was 11.5 milligrams of THC. In the placebo cigarettes, they said they had the cannabis leaves that the THC was extracted from, but there was no THC actually in the placebo cigarettes. All their other underlying medications stayed the same, and they were looking at clinical outcomes. They looked at week 0 and then week 8, and they looked at clinical factors, labs, and endoscopic follow-up. And what they saw was in the groups, the median age was equal, gender was a little bit, in the placebo group, there were more men than women in the placebo group, one smoker, looking at left-sided and extensive UC, disease duration slightly different, but 8.2 years for those who are on cannabis and 6.5 years who were in the placebo, 5-ASA, steroid, thiopurine, and biologic use. This is very small numbers, but kind of equally distributed medication use. And what they found was, I highlighted it, was the patients who were using cannabis, their Lichtiger score did go down at week 8. Their Mayo endoscopic subscore did go down from 2 to 1. Their CRP did go down but was not statistically significant, and their calprotectin did go down but not statistically significant. So they saw some signal in adding cannabis to their management strategy, but still, we see clinical improvement. They saw some endoscopic improvement, but the lab parameters did not improve. They did note side effects in the cannabis group. Patients had more memory decline and dizziness. And as always, further larger studies are warranted. So thought that would be fun to add. Now, biosimilars. Since we are almost short on time, what I'm going to just say is, biosimilars are there, but if we present it with a case, you have a 38-year-old female, newly diagnosed, pan-UC, hemoglobin is 10, CRP is 15. At this time, you recommend dual therapy with infliximab and 6-MP. She's in agreement to take this therapy, and then the insurance company calls you and states, you have to use a biosimilar. So what do? Do you proceed with a biosimilar with 6-MP? Do you appeal to the insurance company to get infliximab, or you just don't know what to do? And so the definition of biosimilar by the World Health Organization is that it is a biotherapeutic product which is similar in terms of quality, safety, and efficacy to an already licensed reference biotherapeutic product. The FDA has a similar definition. They also caveat there are no clinically meaningful differences between the biologic product and the reference product as well. And so I think just to since we're short on time, what I wanted to show is really, this is a slide where showing where are biosimilars being used. And you can see that biosimilars have already been approved and being used in Europe, in Korea, in Australia, Brazil, Canada, and now in the US. So I think the take-home point was there were several presentations on biosimilar use, and a lot of the large European groups did present their data, their experience of it. They didn't see any major signals, and I think they're here to stay, so we need to get used to using them. You can see a whole slew of different studies that have been published, and this was one of the studies that was just showing use of the CTP13 biosimilar for induction therapy, what their response and remission rates were. This is the NOR switch extension trial, so this is where they were showing if you switched in between use, so the CTP13 was the biosimilar. At week 30, they switched to infliximab, and vice versa. Those who were infliximab and those who switched over to the biosimilar, they didn't see any significant change in clinical remission response. Rates continued. So I think this gives us a little bit more information and confidence in using biosimilars. I think we have to probably get used to using them as well. Okay, I think.
Well, so do we want to go through this, or we have 16 seconds? Okay, all right,
Okay.
so last. Okay, so I'll speed through this. So I just have 2 abstracts to discuss here. And Miss A, she's 39, she has moderate to severe ulcerative colitis, and you started her on azathioprine. Her TPMT is normal. Despite starting her on a lower than weight-based dosing of 100 milligrams, she develops neutropenia within 1 month of starting azathioprine. Why is this? So we know about thiopurine-induced myelosuppression, that we check TPMT to try to really detect the population that would be at risk for this. Those that have enzyme deficiency, really, it's a small portion of the population, 0.6%. But when we look at the patients that experience this TIM, I'm going to call it TIM, it's only in 25% of European patients. Now, in the Asian population, it's very interesting. These TPMT variants are actually more rare, 3% versus 10%, but leukopenia is actually more frequent. So you see that in 30% versus 5%. So they noted that there's a new gene variant in this Asian population, the NUDT15 gene variant, and it's associated with thiopurine-related leukopenia. And here in Southern California, we see quite a diverse population, so I actually think this is important for us to really consider. And the NUDT gene, you actually can, it is commercially available to check for. So just to go into detail, there was a study that looked at looking at NUDT variants in not only the Asian, it was actually looking at the European population as well. And they looked at 491 cases of TIM. They looked at 734 thiopurine-tolerant IBD controls. They looked at, they associated with genetic variances, cases, and controls in exome sequencing. And essentially, they did find one new gene variant in the NUDT gene, but they also concluded that there are roughly 7 coding deleterious NUDT15 variants in TIM. This was all verified in independent cohorts. They found that basically carriage of any of these NUDT15 coding variants led to 22-fold increase in the odds of TIM, and this is independent of your TPMT status or a thiopurine dose. So essentially, why is this important? So for every 100 patients genotyped, 2 patients will carry this NUDT15 mutation and need alternative treatment to prevent TIM in 1 patient. And that pre-treatment NUD15 genotype could potentially reduce our risk of really having TIM in patients. They can be added to TPMT testing. And we can see that the greatest risk of this TIM happened in patients that had both the TPMT and the NUDT variants in the European population. So I do think this is going to become an important part of our pre-testing for safety for patients on immunomodulators. Last, we're going to talk about whether combination therapy really is mandatory. So a lot of patients don't want to be on combination therapy, but there may be a really important role for this. So there was a study that looked at a gene variant in the HLA gene variant, and this particular cohort is really impressive. So it was put together by a UK group. It's a 3-year prospective observational UK-wide study that investigates infliximab, adalimumab, and biosimilars, and they looked at primary non-response, loss of response, and adverse drug reaction. They included patients that had active Crohn's disease by those definitions. It involves over 118 hospitals over there. It's really pretty impressive. I'm not going to go into detail of all the definitions, but they looked at, had very specific definitions of what they included as primary non-response remission and treatment failure and immunogenicity. And here, what I want to highlight, their primary non-response rates were roughly 21 to 26%. Remission at 54 weeks was roughly 34 to 40%. Immunogenicity at 54 weeks, so at year 1 was 11 to 28%, and by year 3, that increased to 23 to 42%. And the upshot of all this is that when you're on concomitant immunomodulators, you really do reduce that risk of immunogenicity for both infliximab and adalimumab. And what I also thought was really powerful about this study was they also genotyped these patients and found that there was association with increased immunogenicity with an HLA gene variant. So they found that this HLA DQA105, so in these Kaplan-Meier curves, basically the top in the green is someone that does not have that. So if you're on immunosuppressants, your rate of developing these anti-drug antibodies are really low. But let's say you don't have these, you're not an immunosuppressant. If you end up having this gene variant, you still have a very high risk of developing anti-drug antibodies. So at the very bottom in the red, so these are patients that have this this HLA variant that are not on immunosuppression. And these patients are at really high risk, and it seems to extend beyond 700 days of developing anti-drug antibodies. So why is this important? So I think pre-treatment genetic testing will help us really clarify individual risk profiles and targeted use of immunomodulatory therapies. We also know that for this particular risk allele, 40% of those with European ancestry carry this, so it's actually quite prevalent. And we know that the presence of these HLA risk alleles will increase that risk of developing immunogenicity within 1 year. So it could be that a subset of these patients really need to stay on combination therapy with infliximab. And I think really what we wanted to target, Dr. Targan will talk more about this later, is that the field of IBD is becoming quite confusing. We have a lot of new therapies, and I think that it's also very exciting. So I think we just need someone to help sort this out, and hopefully that will be Dr. Targan. So we'll see. All right, thank you very much.